Good afternoon, everyone, and welcome. Thanks for joining us this lunchtime. Hopefully you're all in the right place. We're bringing to you an event regarding record keeping, safety netting and confidentiality. We'll start with introducing ourselves and then we'll go through a little bit about what we're expecting to gain from today's session, the agenda, some introductions and housekeeping, then we'll kick off. I'll start by introducing myself. So I'm Minali. I'm a GP by background. I'm also a educator or an associate with the Nottinghamshire Alliance Training Hub. And I've also got a role as a educational lead for a fellowship scheme in Nottinghamshire as well. And today's event is brought to you by NATH, and my co-presenter is Saira.
Yeah, hi everybody. I'm Saira. I'm one of the GPs as well. GP Associate for NATH, which is a training hub, and sort of co-lead for multi-professional support unit, and also work with NHS England at the moment for quality assurance. But yeah, welcome to the talk. Look forward to running it. And should we go on to the next slide just to see?
Yes.
Do you think it might be helpful for us to ask people just to write in a chat box quickly where
I
they're
think so.
yeah, what the roles are, because that really helps us sort of understand your background a little bit. So, yeah, just write what your role is and where you're based, perhaps, and that'll be enough. Thank you. So
So
we've got
we've
lots
got,
of care coordinators, social prescribers, got a mental health practitioner.
fantastic. Let me move on. Just a word of advice for today's session. So what we intend for this to be is more of a general guide, but what we'd like you to do is just to ensure you follow the local guidelines and regulations related to your organisations as well. So every workplace, every organisation has its, I guess, unique set of rules per se, and make use of templates that are perhaps unique to your organisation. And if you do have any concerns when you're at work related to things like record keeping, consent, confidentiality, etc., do seek advice from either your Caldecott guardian or your line manager, who will hopefully point you in the right directions and hopefully clarify any issues you might have. So just an overview of our agenda today, and what hopefully your learning outcomes will be and will be met during the session as well. So we'll start with the first approximately quarter or a third of the presentation will be regarding documentation and record keeping. So that will be related to either consultations or any form of patient interaction you might have. Then we're going to touch upon the recent changes that have been implemented, and that's more related to patient access of their own records, something that you most probably all know a little bit about, and a little bit about how the fact that patients now have access to their records may have an impact on our practice and what we do and how we make how we record things. And then in the second half of the presentation, we'll also be talking about safety netting, why it's important, and how to go about safety netting. And then the final part will be touching upon consent, but also confidentiality as well. Hopefully this all aligns with what you're all expecting. If you do have any further questions or you wanted to gain something else from the presentation, do ask as we go through, because we can hopefully clarify any questions you might have. Just looking at the chat as well, we've got more care navigators and senior PCN operations coordinator at Arnold and Calverton. Fantastic.
Yeah, it'll be good if you could introduce yourself, but thank you. Sounds like a good attendance today. So yeah, let's crack on.
Fantastic. So we'll start with the section regarding record keeping. Okay. What we'd like you to do, if possible, is start a little bit of interaction. So if you all go on to www.menti.com, you can do this on your mobiles, or if you've got a spare device, or if you've only got a computer, you can by all means do it in the background. And what we'd like you to do is answer this question. So when you think of record keeping, what exactly comes to your mind? What do you think about? We'd like you to perhaps think broadly. So what sort of information or data might be recorded? Why do we carry out record keeping in the first place? And in what ways can records be updated, and how can information be stored? So if you go onto menti.com, type in that code, or there's a link there if you prefer to use it that way. We'll hopefully get a word cloud up. Just give me
You
one
won't be
moment.
able to use the link if you're sharing, isn't it? So unless you copy and paste the link, but I mean, you can just go to www.menti.com and then, oh, people are doing it already and add the code. Perfect.
Yeah,
Thank you.
fantastic. Hopefully you can all see my word cloud, I hope.
Yes, yes, we can see it. Thank you.
Fantastic. So you've got some excellent ones come up. We've got personal information, patient information as well, confidentiality, electronic versus paper. Fantastic. Yeah, that's really interesting. GDPR, yes.
Just put date of entry, secure, concise, name of clinician, accuracy, security. Yeah, all really good.
Time entry as well. That's excellent. Really, really good.
Suppose in a timely manner. Somebody's put timely.
Fantastic. I'll give you all a couple of minutes just for those of you who are still trying to sort out the IT side of things.
Got about 10 responses down here.
Okay.
So bigger the word is, obviously more of you have possibly put that in. So a lot of you have put confidentiality and personal information.
Continuity as well. That's quite a nice one.
Data protection, continuity.
Lovely. Shall we move on? Wonderful. So we'll start with a quote basically from Twitter. And what we want to do is hear your thoughts as to how you feel about this. So a lady called Ruth popped this on Twitter. So this might have been in her insurance records, but my age was coded wrong. So I started getting frantic calls from my insurance company to manage my high-risk pregnancy because they thought I was 80 years old. I told them that would be a medical miracle because I was 35 at the time. What do you all think about that? Do just unmute. We're quite a small group. Do you think that's a common occurrence? Are you shocked by that? Or do you pop your thoughts in the chat? What do you think about it?
Olivia's were frustrating but not surprising.
Yeah, you're so right.
It's a sad mistake, isn't it, really? But can happen.
Any other thoughts?
How annoying for her, bless her.
Yeah, I can imagine it being very, very frustrating and a lot of time and admin having to resolve that, especially with insurance. Saira, what do you think? What are your thoughts?
Yeah, I suppose these things happen. But if you look at it from organization perspective or patient perspective, and patient perspective is definitely, individual level, I'd be really crossed if this happened to me. And I'd be like, oh, how could you make that mistake? But then I suppose it's looking at organizational level as to how that mistake happened, or, that's where the record keeping is really important.
Yeah, absolutely. Yeah, you're completely right. I think if you see it from a patient point of view, obviously it's incredibly frustrating, time consuming, and I imagine it being very, very, yeah, absolutely. Diane's pointed out it's annoying, but where was the common sense? Absolutely. So you can only assume it was human error in the sense that someone's date of birth was put into a computer system incorrectly. But yes, you do wonder about the common sense side of things from the insurance company point of view, especially if they're thinking that she was pregnant to the age of 80. But yes.
Okay. Yeah.
Lovely. So we'll move on to record keeping in a little bit more detail as to what it is, why we do it, and how can we carry out record keeping. So the various ways in which it can be done. So what is record keeping to begin with? So formally, definition, I guess, is the method by which we keep detailed information about a patient. And that's not just during a certain instance, it's during the whole of their lifetime. So information that would be recorded, examples would include things like their condition, what investigations are being carried out, perhaps the outcome of those investigations, any diagnoses that are being made, alongside any treatment or management plans that have been implemented as well. And that can be certainly very, very holistic. I think some people think it's only medical information that gets recorded, but actually do think that management and treatment is a lot more holistic. Anything we do with a patient, be it just a phone call informing them of something, I guess letting them know about an appointment detail, any form of interaction should be recorded, regardless of whether it's clinical or not. Does that make sense? Any questions or queries regarding that at all? No, I'm getting shakes of the head. If you do have any questions, do just pop them in the chat, or by all means do just unmute and speak up. So why do we do it? What is the purpose of record keeping? So first of all, the primary goal, of course, comes down to patient safety. What we want to do is ensure that we're recording all that information related to a patient so that we're providing the most optimal care to that patient, and that care that we're providing is safe. Record keeping also helps to avoid any delayed diagnoses as well. So the objective is, of course, to share the information regarding a patient amongst our colleagues. So say, for example, you're working in a GP surgery, you don't necessarily see the same doctor all the time, do you? You want to make sure that the colleagues who work in the same practice know what's going on with that patient, but it's also that continuity of care with other members of staff who might not be at that practice. So things like out of hours services, sometimes even parts of the record, things like the summary care records, might be visible by other members of staff as well, things like walk-in centres, A&E departments as well. So it enables that safe handover of information regarding a patient to colleagues, be them medical or sometimes non-clinical as well. There's also benefit from a medical legal point of view as well. So say, for example, a mistake or suspected mistake has been made, and then of course those notes are there as, I guess, evidence to back up what was done or what went on during a particular event or consultation. So it's involved in litigation, but depending on what's recorded within the records, it can also be used to help reduce the risk of litigation, should there be any I guess any ambiguity regarding what took place during a particular event or consultation. And then related to lost revenue and reimbursement as well. So that's if there's any issues related to payments or anything like that, or should there be any changes or anything like that, then reimbursement's also relevant as well. What do you all think about this consultation? So we've got Sarah Partridge, a clinical pharmacist, who is recording regarding a patient called Minnie. Under history, she's recorded that Minnie is not sleeping properly, sleeping in her sister's front room as housing issues. Examination, denied mental health issues, and then the plan, refer to social prescriber for support with housing. If concerned, speak to GP. What are your thoughts? Olivia saying, what are the housing issues? Absolutely. Absolutely. Any other sort of vague bits in there, or any other queries or questions that come to your mind? Letitia, absolutely. It's very brief, but not much other detail. Diane, absolutely. Where is the consent for the referral? Certainly. Esther said, how long has this been going on? Not enough information from Alexandra. And Livia's also asking, what are the sleep issues? Absolutely, everyone. Any final thoughts or points about this one? Limited information, certainly.
It is just short, isn't it?
Yeah, absolutely. So it's quite short and sweet, and quite vague, I would say, as well. Limited information, doesn't really go into much detail as to what the sleep issues are, what the housing issues are. So it's just not. Why did the consultation take place? Absolutely, Julie, what was the reason for the consultation to begin with? Because of course it's a pharmacist carrying out this review, who's usually related to medication, isn't it? So what was the reason for the consultation initially? Yeah, so completely right. I think we're all in agreement that this record is just a little bit too brief, doesn't really go into enough detail as to what is going on with Minnie. Whereas in contrast, we'll show you the next slide, which is certainly more detailed and hopefully might answer many, if not all, of the queries that you've all raised. So we've got patient asking for sleeping tablets. That's clearly the reason for why the consultation was booked in. Patient ID confirmed. It's during the COVID-19 pandemic. it's a face-to-face consultation rather than it being over the phone or virtually or online via a messaging service. We've got the duration of the poor sleep. And then we've got a little bit more detail regarding the examination. We've got a mental health screen completed. We've got a risk assessment as well in terms of suicide and self-harm. We've got a little bit of a safety check as well in terms of support networks, mum and sister involved. And then we've got a lot more detail related to the plan. What do you all think about the plan? Any thoughts or points to raise about it? Yes, Nicola's saying it's more detailed, certainly. Georgia agrees, very detailed plan.
I quite like that it's been coded really nicely as well, isn't it? So like there's a depression screening underneath, questions used, signposted, face-to-face consultation. I mean, I probably won't do all of those codes, I'll be honest with you, but it's still really good kind of documentation to do as much of that. And yeah.
Absolutely. So Nicola's said that she's listed the services really well. Absolutely, I would agree. So we've got the mention of the social prescriber, IAPT, which is improving access to psychological therapies, referral to the GP as well, 111, 999, Samaritans. And Olivia's mentioned that contingency plan as well. Absolutely. So we'll come on to this in the later part of the presentation as well, but looking at that safety netting as well. That's been well documented, and also a bit of a timeline's been put in there as well over the 1 to 2 weeks as well. And then Diane's mentioned the fact that it's easy to read. Absolutely. So it is nicely laid out in a sense, the way it's got plan 1, plan 2 listed in bullet points. So if someone else who is separate from this consultation goes ahead and reads it, they can probably get the important information in quite a fast amount of time. Lovely. Any final points to raise about it in terms of the first one versus, so we'll go back, if it lets me. We'll go back to the initial consultation. So just as a comparison, hopefully that's a little bit of an idea of what we're aiming for in optimal record keeping. So in terms of recommendations for record keeping, some of which some of you have already pointed out, but what we're hoping for it to be is as accurate and as clear as possible. And what we mean by that is by accuracy, we mean recording factual information that 1 or 2 of you already brought up in the word cloud as well, making it clear. So what you don't want is for your records to be ambiguous and sort of contradicting each other, keeping it as concise as possible, but informative. So what we mean by that is providing that information, ensuring you're getting your point across, but not listing long paragraphs, because you've got to realise that colleagues are reading this information. You want it to be as timely as possible for your colleagues to get the information out of the record. Contemporaneous, what we mean by that is for that record to be carried out or put onto the system at a similar or same or just after when that consultation or interaction took place. What we're aiming to do is try to avoid carrying out several consultations or patient interactions and then maybe after half an hour or 1 hour, or even worse later on at the end of the day or at the end of the session, then recording your notes, because that's when, of course, mistakes can happen, and that's when that can lead to more errors or ambiguity in the notes if you forget what took place. Using the appropriate method to record notes as well. So I think we come on to use of IT a little bit later on as well, but talking about use of SMS or text messages or Accurix or MJOGs, I think they're called as well, for patient communication. So making it clear what method has been used to communicate with patients and recording the type of method used in the notes. Using summaries or templates when possible, as well as read codes as well. So Saira already touched upon read codes. I'll just go back. So these are the bits that are in green on here. So for example, the referral, it's got this code at the end of it. Signpost to IAPT has got this code, and referral to GP has got, so these are called read codes, and it means that information is a little bit more easily auditable in the future, but making use of templates as well. So you might have access to F12 templates, you might have access to Ardens as well, depending on where you work and what your organizational system's like. But then again, that again makes the system a little bit easier to use, and it makes the information a little bit more easy to access as well. And then I've already touched upon this, but trying to avoid excess information or unnecessary details. So try not to write in big, long paragraphs. And it's a very personal decision to make, I think, about sentences versus bullet points. I don't think there's any right or wrong here, but as long as your information is recorded, it's concise, and it's not too bulky, then you're fine. So brief sentences are fine, but I think it can be quite time consuming if you were to always write in full sentences in the patient's notes. So it's weighing up the pros and cons of sentences versus bullet points. And at the end of the day, we're all individuals. Everyone has their own way of recording notes. And it's about, I guess, gauging what your personal way of recording notes is and what you prefer to do. Does anyone have any thoughts about sentences versus bullet points? What do you all do and what do you prefer to do and why? Or have you not really thought about it? Saira, what do you do?
Helen's would depend on what information I'm giving. Yeah, so I find my mental health notes are quite long, for instance, if it's first consultation and things like that. And I think, again, is finding the right either template, Ardens or something that you might use, or using, I mean, some places have like social history separate heading. So I don't use bullet points, but I do write sentence and then next sentence, and then rather than just continuous paragraph, because I think that can be quite hard to read. So I do try and write separate sentences. Yes. Bullet points, again, it takes time, doesn't it? It's just adding an extra time to do one, two. So I don't do that. But like, for instance, if I do have a plan, I think similar to what possibly Sarah had done, that do one line referral to this, then SMS sent or whatever. Oh, I think she's put dashes to next to it. I don't think I do that, but yeah, that's more thorough of number one. Number two, I probably don't do that, but I do like referral to social prescriber made on one sentence, and then the next would be, discussion about mood or sleep, then third would be talking therapy, and then fourth, like that, I will go down. What about you?
I mean, I tend to write, I think I write in bullet points, but I tend to be a little bit more, I mean, this is an opportunity for me to learn here, actually. I tend to be a little bit more prosy, I think, rather than, I don't think I start, what I'm trying to say, I don't think I start a new line with each bullet point, I'm thinking. And that's partly to save space in the medical notes, I think, because I think if I'm listing downwards, I think my entries could be quite long. But actually, looking at this, it looks like most people do actually prefer bullet points and starting a new sentence. So maybe that's something I can improve on in my notes. I think I'm just a little bit stuck in my ways as well.
So I would say it's like the context, isn't it? You can't write every
Yeah.
sentence, but say you are touching on, say you talk about mood, then that would be together. Then you're talking about sleep, they'll be together. Then if you're talking about social history, they'll be together. So you still group them, because you can't write every sentence like separate, but like, or any medical problem. So for instance, if there's any negatives, or then I will write like no vomiting / diarrhea, all of that in one line, and then the next line would be, so it's just, I don't think there is a right or wrong answer, but I think it's essentially how they can be made concise, but also the following person, how they can follow it quite quickly, because it can take time for someone to read through all the notes. If you're seeing the patient, you're going to have to catch up with all the previous entries. So yeah, but what have people said?
So people have said generally, I think, prefer reading bullet points, but it depends on the nature of the entry. Some people write in sentences, but start each sentence on a new line, so it appears to be bullet point style, which makes
that's how I
sense. It
do
sounds
it.
like that's similar
Yeah.
to what you do, Saira.
In the plan, certainly I do that, but in the notes where there's history, again, I'll group it. Like I won't do every sentence separate, like you said, that'll be massive, but group some of the similar symptoms together. But it's hard, and I don't think, like you said, as long as it's all there, I think, yes,
Absolutely.
it'll be ideal to be as concise, but it's all time dependent and patient
Absolutely.
dependent and everything. So yeah, same with you answered, my first consultation longer. Um, well, you get an hour. We don't. But even then, I find my first like time, experience is way more information than a follow up. Um, yeah, perfect.
Lovely, thanks everyone. So just some common pitfalls and tips that you might have encountered yourselves. I think I've certainly experienced all of these at some stage during my medical career, and I'm happy to admit that. So recording in the wrong patient's notes, I've certainly done that in the past. Delays in documentation, yes, when you're running behind and you've got, I don't know, 5 patients waiting in the waiting room, yes, I have certainly not documented immediately and seen another patient and then got myself into a little bit of a twist because I can't remember their observations. Incorrect information being recorded, perhaps to a certain extent, yes. So I have had to mark things in error in the past when I've realised that I've typed in the wrong information in a wrong patient's notes. So yes, I'm guilty of all of these at some point in time. I guess a lot of it is down to human error, but also time pressures, system pressures as well. Running behind doesn't help as well, of course. But ways in which you can help prevent this is, of course, checking the patient's ID and doing that multiple times, and not just one form of ID, doing multiple forms of ID. So usually what we do is name, date of birth, and first line of the address, just to confirm. And especially when you might have we've got quite a few patients, for example, called Michael Brown, hypothetically, or John Smith, whatever. So if you just say that name, there could be 5 John Smiths on our records. So it's checking that ID, ensuring that you've got the correct patient, but doing so multiple times if you do have multiple patients' records opened. Trying to avoid having too many records open simultaneously. I know that System 1 only allows you to have 4 records open at the same time, but I feel that even having 4 open, it can be opportunity for error there. So, and try to avoid interruptions. I know this is very much easily said than done, but it's the moment those interruptions happen that one is more likely to make a mistake, unfortunately. And aiming for that timely documentation as well. So what we mean by that is having that patient interaction, a particular event or consultation, and trying to document as soon as possible after that. That way the information is more likely to be accurate, you avoid any delays, and you help avoid any of these pitfalls as well. Any questions or thoughts about those? Are these pitfalls that any of you have encountered yourselves, or am I just unlucky, or am I too disorganized that I've encountered them? Has anyone else been in my
I think the
situation?
biggest thing is one patient at a time kind of deal. I think EMIS actually takes you to directly to a patient, doesn't let you open 2 at the same time, but at the same time, just have to be really careful with. I think that's the biggest way that you can make mistake, is if you've got a few open, then it's very easy to record it in the wrong patient. Yeah, that's happened to me when I've opened a few, and then I'm like, oh, okay, that wasn't for this patient, that was for the other patient. And then I think that also the biggest thing is, even if the patients are waiting, try and finish what you can. Sometimes I have gone back to edit it in a bit more detail once a patient list is finished. But try not to, because I think when I started training, I used to do that, is to avoid patients waiting. I just write a short thing and just move on to the next and then next, but you forget. So don't do that. And again, all of you maybe perhaps don't have, some of you might do, and some of you may have less time pressure, but like for instance, for GPs, 10 minutes, 15 minutes, you really got to sort of write quite quickly. So, but yeah, those are I think the biggest things, isn't it? Don't open too many patients for sure. Just try and deal with one at a time, and write when you can whilst you remember, unless obviously there is a clinical demand and there's something that's more urgent, then you obviously have to attend to that. But yeah, what somebody has put, no, I've documented the wrong patient. Yeah, I think that's quite a common one. I've done it.
System 1's quite good because it does actually put the box around the patient details in a different colour, so you know that you've got more than one patient open at a time. So with that bright red box around it, it does make you go, oh, hang on a minute, let me just double check that's the patient I'm meant to be documenting into. So I think they have tried to sort of.
They have, and even when you're sending something like on a QRX, I know when you're sending like sick note or something, fit note, and I think some of the documents it says, "Are you sure this is for the right patient?"
Yeah.
So I think there are reminders, but it's still obviously we need to try our best not to make those errors. Patients don't like them, do they? I think from memory, I might have written someone being pre-diabetic when their HbA1c was normal, and they got because it was again, when the test results were being filed, and it was a really busy day, and again they were very unhappy about it because obviously they said, "Well, I've never been told," and all this, and apologized about 10 times, but obviously they still kept on. Every time I had this consultation, they're like, "Oh, are you the one who told me?" I was like, "Oh, okay." So you have to be, obviously, consequences do matter. So yeah, try hard not to make mistakes, of course.
Yeah. Edar's added something in the chat. It's hard to avoid interruptions, especially when being the only nurse at a workplace during a shift. Absolutely. And it is difficult. And one thing to remember is that we are all human and mistakes do happen. And especially when we're busy, if you're the only clinician in during a shift, and we're all only human, but I think it's being aware that mistakes can happen and doing what we can to mitigate. So hopefully these tips will give you a little bit of an idea of little things you can do during a busy day, just to hopefully avoid any of these occurrences.
Yeah, on that note, I get given that a lot. Can I debrief with you? Can I come and ask you this question? This people send screen message, but I try and finish it and then say, yeah, free now. Because if there is something really urgent, I'm sure they'll knock on my door. So yeah, creating those boundaries again, and making sure you've done. It's very easy to say, I know, but try to do that. Try to make sure you finish what you're doing, then attend someone else's question, unless it's really urgent, like I said. So.
Yeah. Absolutely. And I think the issue, I mean, I'm not sure how many of you are prescribers, but I think especially if you're prescribing something or calculating something, then try to make sure you do that before you start another task, because I've certainly made the mistake of thinking I'm prescribing something, and then it turns out I prescribed it in the wrong patient's notes because I've been interrupted, but I've noticed and gone back and deleted it and prescribed it in the right patient's notes. But that happened because of an interruption. But it was my fault. What I should have done is finish my prescription and then started something else. So it's, as you say, trying to finish what you do, even if it takes that extra 10 or 15 seconds. So lovely. Thanks, everyone. We'll just move forward. Okay, just conscious of time. So right now we're going to hand over to Saira, who's going to talk a little bit more about the recent changes to patient access. Saira, thank you.
Yeah, thanks. So as we all know, now the patients have got access to their records. And I think it started in November 23 officially, and obviously different practices have been doing it gradually, but the patients can access their notes either on NHS app, or they can go on NHS website and register their details, and as long as they're 16 and above and have got their ID on them, they're able to access. But it is all the new entries. We're not talking about historic information. They won't be able to see that unless they've got right to access at any point, but they have to request that specifically from the surgery by saying that I need, for this, and then sign it, etc. But it's one of those things that any new entry has to be. We have to be now a bit more careful, I suppose. It's always been the case because patient could always ask for, access, but now it's quite readily available. So, people have, I know in surgery, somebody called and said, well, I didn't quite, just about someone else, but they said, I didn't quite say it like that. I think they misunderstood me. Those things are gonna, sort of more sort of being aware. But I guess the reasoning behind it is to give that, patients that independence of sort of managing their own care. So things like appointments can be up there, investigations and things, they can have a look, they can compare it from before. So there's pros and cons, I think for clinicians puts an extra pressure of, making sure that, again, the mistakes don't happen, etc. But the highlight is that everything will be seen, and you're not, apart from redacting certain information from the notes, and the biggest one is safeguarding And we'll touch on that in a minute. But there are exceptions. They won't be able to see, like if you send tasks to, they can't see that. If you mark something in error, they won't be able, they'll just get taken off. There's the appointment details. So, on the ledger or on the homepage, when you're saying, when the receptions are putting appointment for sleep issue or mental health, or where, they won't be able to see those things. Same with, reminders, recall. So I think they can see their next appointments, obviously, when they are, but they won't be able to see what might be internally called as a recall. So those are some of the exceptions, but everything else, they can obviously see it. Yeah, so special notes, Minali, what did we say yesterday was a special note? So like,
So the special notes.
Homepage, like the warnings. Yeah, I've got it. So for instance, on system 1, for each patient's homepage, there might be something including things like this person can be aggressive verbally or whatever, and that's a special note on homepage. They won't be able to see that. Same with certain other messages like emails, for instance, that it'll just flash, won't it, to say patient likes to be called this, or remind them of this next time, remind them to bring an ID next time they come into the surgery, things like that, which are, they won't be able to see that on their system. And I don't know I think one of the good ways of actually doing it is registering yourself with the NHS app as well, to see what you're able to see, because it's actually not every, like you think that there is a lot there. Yes, you'll be able to see your problem list, what kind of maybe diagnosis. I think we covered that in the next bit, don't we, if you go forwards. I think there will be another slide, but I think the reasons why it's being challenging, so is that okay? Is that what special notes would mean? So the challenge comes with obviously wanting to be sure. Again, we talked about how we need to be really careful not to write in the wrong patient's notes or doing a wrong prescription, or because obviously that's, again, something you don't want. And so for instance, the other thing is recording test results and things which might not be suitable for all of you, and it might be just the doctors in your practice do that, but it is an example that somebody is. I went onto the record and to look for any blood results that might have come back, and it said urgent referral, request suspected breast cancer. So Christ, the doctor thinks I've got breast cancer now. So it's things like that. I mean, sometimes chest x-rays come back and it says a shadow on the lungs, query, investigate it further for cancer, and something like that to be found on an NHS app and not being, sort of discussed with the patient is a bigger shock they can have. So avoid those kind of like pitfalls, and things like, sort of being careful about the words used, I guess, and with the weight and obesity and things, I think people do get a little bit upset. But having said that, we were having this discussion that actually it is important for them to know. We're not going to hide the weight from them as such. If that's something you've discussed in your consultation, that consequences of sort of weight gain, discussed, or the future health risks like high blood pressure or diabetes and things, I think that's fine. You have to write, you can't remove it. So I think nothing should be removed unless you think there's got consequences, like test results, have to be really careful that they're communicated to patient. It doesn't just come to them as a surprise that they're diabetic or they've got cancer or something like that. Same with safeguarding. That's something, we can't take a chance with it. But I think everything else, needs to be there, and it's okay if patients are going to get a bit upset about looking at it, but that's the reality. And they're going to be there in the consultation. So it's how you've handled the consultation rather than how you've written it. So things about like drug abuse. Yes, so factual stuff like weight is this, discuss the challenges that or health consequences of or risk of diabetes and risk of this, and measures discussed, offered weight loss strategies, or again referral to social prescriber. If you keep it factual, I don't see why people would object to it or have a problem with. But I think it's more actually, if anything, rather than record keeping, is more of a communication skills and consultation skills when you're addressing it as to how you actually take it because some people do get very upset about it, like, you know, why did the weight just suddenly come up? Things about drug abuse. I think when I previously run this talk, people were really concerned that sometimes people will tell you about drugs and alcohol, and they'll think, actually, you know, I'm only telling you, you know, please don't tell anyone. But again, you need to be quite clear that all health professionals can access their record. And it goes without saying that people who are directly involved in the care will be able to see it, but it's confidential, as in we're not going to release it to anyone outside that. So again, being careful about, you know, as long as patients are aware, it's fine to write about drug abuse. Domestic violence, again, an area where you need to be really careful, because again, it depends on if their partner is being coercive, or they don't want them to go and seek help or see the doctors or health professionals or care coordinators, anybody. They might actually look on there and say, oh, this person did go to the... So again, you have to be careful with certain things. But I think it's a judgment call in a way. It's a professional judgment. But my message is usually you should document, and patients should be able to see everything.
Can I just say that
Yeah.
usually if I'm social prescribing link worker,
Yeah.
if somebody discloses something like DV, I would document, but I would also then safeguard. So I would make it only safeguard appropriate for that information, because you don't know what's going on at home. You know, somebody else could have access to their medical record at home. So once you mark it as sensitive, I always mark it as sensitive information, so then it doesn't appear on the patient record per se for them to see, but it does for health professionals to see.
Oh yeah, so that's what we're going to talk about, how to actually, if there's anything to do with safeguarding domestic violence, then you are meant to redact. It's called redacting the information, which means the health professional will always be able to see it, but patients can't see it on their online record. Yes, you're right. So we'll show you that in a minute, how to do that. Okay, next, and then I'll take the questions at the end of this. So clinicians can choose to redact access or mark particular entries as not visible on online records. So any sensitive data, any risky information, anything that you think will cause distress, like we talked about, certain results, etc. Yeah, you need to, I think the reason I'm saying you can't say that somebody was aggressive to you during a consultation, for instance, I think you have to make it quite factual that the patient raised their voice or were verbally aggressive, you know, and said, for instance, in quotation mark, whatever they said. You don't need to hide that from them, because they know that that's what's happened. But any risk, anything that would be domestic violence, safeguarding adult children, or anything else that you think might upset or distress, which hasn't directly been discussed with the patient, those are the kind of things only that you can redact. Okay, so how do we do? So that's what it says: caution with pathology results, and document certain things that you haven't directly sort of spoken about. I'll just, if you can play the video, then it just tells you how to redact the information. Hopefully you already know how to do this. So far, have you got any questions about it? Any worries about, before I show you how to actually redact the information? Or basically, redaction, all it means is that you're hiding it from online visibility to the patients, but you're obviously not hiding it from any of the professionals, which doesn't happen anyway. The system only allows you to hide it from. Is there any questions around what the new sort of access means, or any questions about what is visible to them, what isn't, or you've got worries about what to kind of redact or not, then please ask away, and then I'll find the video as well in the meantime.
Yeah, I would ask about that.
Yeah.
So I work specifically in mental health, so a lot of my notes are they need to be quite detailed.
Yeah.
And on occasion, that includes writing something that maybe, you know, obviously, if it's a safeguarding concern and it wouldn't be safe for the patient to read that note, I would, you know, kind of redact that or mark that as safeguarding relevant. But sometimes, like you said, there are things that would be distressing for the patient to read, but it's important for other healthcare professionals to know. So like an example would be, you know, if a patient lacks insight into a certain mental health condition that they have, I don't think it would be very appropriate for patient to be reading that about themselves. But it's important for other healthcare professionals to know that information.
I don't know about that because again, why wouldn't you? I mean, I think if they don't have insight, first of all, I'm presuming it's an illness that's been hopefully discussed with them whilst they're doing consultation. So if they do question it, you could explain to say that what this word means, because again, these are medical terminologies. So I don't know if I would particularly redact that, because I do that all the time. We've got so many mental health patients, and we say not maintaining eye contact, or sometimes you have to say things like some signs of neglect seen, or so I don't know if I'm going to redact that personally, because actually,
if you did have someone, for example, where you have signs of neglect, and I'm writing something in the notes that's saying, there was a clear smell of body odor in the room, that's quite embarrassing, and I would say I
know what you mean.
Shame for
someone.
someone.
So now we have to be careful, I guess, how we write that, but I wouldn't necessarily put that in those words. The words have to be chosen carefully. But I think reduction or not being visible, I think, is something, if you want to then add probably a separate note to say further clarification on signs of neglect could and then redact that particular bit, that's fine. But how are you gonna take the whole consultation out, whereas actually patient has got right to see what happened?
I see what you mean. So what do you say? So if you did do that and you made a separate consultation with that sensitive information, when it asks you for a reason for why you're redacting it, or why it's not going to be visible,
I think it's just a text box, isn't it? So you can say
so what would you give for
distress?
I usually put contains sensitive information.
I was going to say that. That's what I put. I put sensitive information.
But if I spoke to somebody about personal hygiene, I'd put personal hygiene discussed. That isn't, you're not saying anything particularly bad there.
Same with if the smell of alcohol, I probably would have raised that while I saw them anyway. So it's not something. So what I think the message is, address anything in the consultation that you think is something that, if you can't address that during that, then you have to think about, ideally all of this should be discussed. The only thing you will redact is where there's implications on the risk to the patient, because even if they're like suicidal, for instance, we write it and they know it, you can't redact that, because actually they've got right to see what clinician and I discussed during that. I mean, that's how my take is. I don't know, Minali, what you think.
Yeah, I would agree with you, Saira, in the sense that I don't necessarily remove information just because it's upsetting or distressing. And actually things like foul body odor, I tend to actually put in the notes, and I do leave it in the notes actually, because usually it's something that I might have picked up with patient about anyway. And if I do notice something about patient appearing unkempt, for example, or a foul odor of alcohol or something like that, I tend to leave it in the notes, to be honest with you, because it's a factual observation of the patient. And typically,
I know what you mean about being
typically something I will have discussed anyway.
Yeah, so you could say you're not sort of looking quite yourself. Is everything okay and things? And then you say that, discuss this or notice it. I don't think we should be scared of saying this, because I think about it. If what is going to happen as a result, they might challenge to say, why did you write it? And you just explain then that it's a fact that these things need to be mentioned because they're a sign of mental illness, or it's not a judgment or anything. You'll be able to explain, as long as you're able to explain it and it's not medical legally wrong, then I think it's fine to leave things in most of the time. Okay. Any other questions on this? Okay, so I have found the video. Hopefully mine will work.
Prospective access to medical records is something.
Can you hear? Yeah, perfect. Okay.
That's coming very shortly, and there may be times where it is actually sensible and safe not to share parts of the medical record with the patient. In order to do that, you do need to redact that information. In this episode, I'm going to show you exactly how to do that in System 1, and really quickly as well. Let's tech enhance your primary care and learning. So to show you how to redact information in a patient record, simply you need to go to the tabbed journal and look at the record itself. As you can see, we've got this entry on the 18th of October. There's a safeguarding entry, and I don't want this visible to the patient, and therefore I need to redact it. As you can see, currently looking through our patient visible section, that entry is partially visible. Stuff like template information and that kind of thing is not currently visible because this is a detailed record access rather than the full record access. However, if you wanted to stop this from being visible, simply you need to go to the entry, click on it, and then go to this world clock icon, click and select, and then you've got the choice of either show in the online record or do not show in the online record. And obviously to redact it, you need to click on the do not show in the online record. We'll then ask for a reason. So if we put safeguarding, and then that will now come up with the icon that shows the world and a cross sign next to it. This therefore means it's now redacted the entire entry from the patient record. Do not use the hand and the mark event as private. That does not prevent the information from being shared to the patient. It's important to remember that is a different setting. If you want to check, if we go back to the patient visible section, as you can see, that entry from the 18th of October is now no longer visible to the patient. If you did that by accident or you were trying to make it visible, simply just go back to the entry, select it, and show in the online record. And as you can see, that entry is now back on the 18th of October, visible to the patient. And that is how you redact information for prospective access to medical records in.
Okay. And I think those of you who use EMIS, there might not be many of you, but you literally right click onto that particular entry that you've made, and you put when you right click it will give you an option of online visibility or not, and you just again do a similar thing. With system 1, it is a bit more about making sure that world sign is clicked. Okay.
I think you can do it from the icons as well at the end of your text line. If you right click on where the icons sit at the end,
Okay,
it'll
brilliant.
bring the world bit up just to make it easier if you can't
Oh,
do the
perfect.
processes.
Thank you. Okay. So hints and tips now of home visits. So those of you who do home visits, it'd be quite interesting to know how you do things as well. So laptop versus printed notes. So again, I mean, I'll give you my example. We don't get laptops for the visits. Okay, we might get it for nursing homes or care homes or something, but majority of the times we just have to do it on the printed notes. So you need to be very careful about a written documentation. So it'd be interesting to know if you can put it on the chat or have a discussion of what do you guys do? Do you use laptop or do you use printed notes? And if so, how do you go about it? You can unmute if it's easier to just have a chat.
Do any of you do home visits to begin with?
But I'm presuming care coordinators would you?
Social prescribers do.
Yeah.
You do as well. Yeah, you guys do as well.
Usually I have brief notes, what I have for the patient, but I don't have the patient's name on them. So, you know, I might put, I don't know, I might put an NHS number at the top, last 4 digits of the NHS number, and then when I'm in a visit, I might make a few notes, but they'll be just odd snippets, you know, just to prompt me for when I get back, but there'll be nothing identifiable on it at all. So everything is totally anonymous.
Yeah, when you take out your paper version is what you're talking about. Yeah,
but we don't take out paper. We don't print out the patient record. So I know you get a summary care record, don't you, when you go out on a home visit as a GP? So you'll have a list of like the recent med sensitivities and all of that. Well, obviously, we don't need any of that because we're not clinical. So it makes it a little bit easier when we go out, because we can just make bullet points. Like if we're going there for social isolation, we might write SI on the, so we just as a prompt as to why we're going.
Okay, that's good. That's good. Yeah, and the care navigators also is Julie said that minute MDTs, and they're typed and then uplifted. But does that mean you do it on the laptop, everything? I'm presuming no paper record. Is that what you mean, Julie? Yes, on the laptop. Is anyone of you use? Yeah, so that's fine. I think that it does make it easier for you guys. I mean, does anyone print out patient details at all. You're right, we have to, as GPs, I think there will be no way of remembering all the medication or the problem list or the consultation. So therefore, I think one of this really important is to remember the confidentiality in this case. Absolutely important. I'm very careful. I'll sort of keep it in my bag and, you know, make sure I bring it back or shred it and, you know, confidential information, you know, destroy it properly. One of the most common things I think can happen is you can leave it in the wrong place. You can lose it, and I think that's quite a breach of confidentiality and information governance, really. But then, yeah, that's really good. I mean, I think you guys have got sort of in a way more safer ways already, so that's really good. Now, the next thing comes in terms of writing in the patient's notes. Do you do it? When do you do it? Do you have like several visits and then you go back at some point or may go next day to write in the patient notes, or do you do it sort of there and then or immediately after post-home visit? How does that work?
Mine's usually post-visit, so I'd come back and write the notes. If it was at the end of the day and it's outside of work time, if there was something safeguarding relevant that could affect care overnight, if somebody was to present in the out of hours or in acute, I would make sure that important information was documented. So I'd be on my laptop after hours just to make sure that was on, just for belt and braces really, and to help clinical teams. Same with safeguarding. I wouldn't just log off because it's my time to go because I need to safeguard. If I need to safeguard, I need to safeguard, and that takes as long as it takes. If it's late and the documentation is fine until tomorrow, then I'd document first thing, but then I would backdate to the date time of the appointment and the date of the appointment. So
do you write anything?
Because I'd be picking up the consultation. So I'd say, notes done, you know, AM following day from visit from yesterday. So it documents for the audit trail, as it were.
Yeah, perfect. Thank you very much, Yvonne. I think that just explains really well everything that I was going to say. Is that most important thing? Remember, if you don't document it, could it have consequences if nobody else sees the information? And you're right, patient could present in A&E, out of hours, 111, anywhere like that. And if there is a very important information, then you need to to be careful not to. And I think the best thing is, if best scenario would be come back, do the home visit notes and then move on to your things. But I totally understand if it's something completely routine, you might not be able to, but I think that the good medical practice would be to write it. And you're right, I do sort of date and time of the visit on there, but then I'll say written retrospectively post home visit, like it says here, or written the next day but visited on that time, something like that, as long as somebody knows at what time you visited and what time you've written it. Anything else that anyone wants to talk about this before we? Would you document? Yes. Oh, sorry. Yes.
A couple of bits in the chat, if that's okay. Diane is asking, would you document the night before to say done visit, and we'll update the notes tomorrow?
Yeah, I think like we said, as long as there isn't an information that would change the outcome. If it's a routine one where you've discussed. It's a routine follow-up, and I think then it may be okay. Yes, I mean, like I said, the good guidance would be do it on the day, so that's that's the best possibility. But obviously, I think we've had this discussion that say it's completely end of the day, you've got to go home to something more important. Then yes, you could just write a line to visited on this day, and then next day update the notes. But just be really mindful, would this change things if another clinician was to pick up the notes and they got a call? Would it change? Is there an important information that needs to be done? Then what you could do, if you really need to go, you could even phone the practice or someone and say, could you just write that in the notes and say this is a really important bit, and then I'll come up. But like Yvonne said, if there's anything safeguarding domestic violence, I think it's our professional obligation to make sure it's documented. I hope that it's a professional judgment, but like I said, routine stuff, there's maybe a leeway, yes. But if medical legally, if something is really important, that, so say I'm a GP and you've done some visit and there's been a very important information that would help me, and I get a call about something and I didn't have that information, it'll change my management. Then I will say, oh, I wish that was documented on the timely manner. So just think about the consequences. If you think it is not going to change particularly any management, or it's got no risk, I suppose you could wait. Does that sound okay, Minali? What do you think?
Yeah, that's completely what I do and what I would do. Nicola's just brought up the fact that at PICS, their acute home visiting service do have laptops, and they have access to System 1 Live when they're on their home visits and in patients' homes. So yeah, that's fantastic. And if you do have access to a laptop, in a way, that makes things easier in a sense, because you don't then have to write down anything. You don't have that printed information that could be a risk or could be a breach of confidentiality if it's left lying around. So in a sense, so for example, I'm a GP. When I go out and do my nursing home ward rounds, I get a laptop to take with me. And in a sense, that avoids a lot of the risk that can occur. No printed notes. It's obviously contemporaneous as well, because I'm doing the notes in the home rather than doing them retrospectively. So it helps mitigate the risk considerably. But of course, it's comes down to funding and resources, as it always does, unfortunately.
Yeah,
so those
I mean,
laptops are few and far between, we'll put it that way.
Exactly. If you've got the laptop and that's connected to your live version, there's nothing better than that. That'll be the ideal situation, isn't it? But
Gold
there are,
standard.
yeah, that'll be the gold standard. But like, I know for myself that if I have to do a home visit in between the clinic, I just have to print it off, be really careful, come back, write my notes, shred all the information, and do it that way. Sometimes you're on the home visit, you might want to admit patients and things, then we have to obviously write another thing for the hospital and leave us safe with the patient, or something, so you just have to be really, as long as you're aware, as long as I think that's the most important thing. Right, next bit. So some of you might do community events. So we don't do them, but obviously session prescribers, etc. will do them. So there should ideally local protocols and templates that will be in place for these activities and events. So use them. So examples would be, say you've gone on taken exercises classes, but it's a group setting for a walk. Then all you could do is just write a generic sort of thing on their notes. So I think we've just got group exercise session run by Yvonne or whoever, and then you just say that, and you don't just be careful not to write another patient's name, which I'm sure you won't, but don't write in the group so and so was included, which I'm sure you won't. But obviously it's just a very generic thing to say, gone on a walking group, run by whatever. The other thing is things like if there is like a workshop, say on a pre-diabetes, the diabetes prevention program, for instance, you could just say, patient attended this program, and diet and monitoring was covered. So just make it really generic, because it is important that we know that this patient did attend these things. But again, being mindful that it could, in a group setting, just write a generic for all the patients. So group write-up is what it would be called. Again, if you're going to somewhere else, like, I don't know, like a school visit or I don't know, somewhere else, then some form of like, consent should be there. But yeah, again, I think you guys do probably know this more than I do. But yeah, any comments or questions on that? Yeah,
No,
so
but Yvonne has put in the chat something related to social prescriber link workers, about how they tend to have they try to have an admin slot or period of time at the end of their working day, and that's usually when they'll compile the notes, but admits that it doesn't always go to plan. Absolutely. That's the issue.
That's the whole issue, isn't it? And it's just pressures and things. And that's why I think the whole purpose of today is how do you do a safe documentation where try not to make mistakes, do a concise, do the important bits on the day, and then rest obviously is professional judgment. But yeah, thank you. Right, should we move on to the next one? So reflection on your own practice. So how do you know that you're doing the right thing, And again, it's very important that we're doing a generic thing, but you need to follow your local policies or trusts or whatever guidance you get given from your managers. or regulatory bodies of yours that might have given you some kind of guidance. So do follow those procedures. The other thing, if you're new to practice and you're not quite sure, have I documented it correctly, you could get either a peer review or a senior review to say, have I done this right? And I do that often when I'm debriefing my any GP registrars or any doctors or even pharmacists. Well, some of the pharmacists do an amazing structured medicine review. So, but sometimes, you know, some of the trainees or students, you might notice that actually they have asked the right questions, but they never wrote that piece of information. So I do give them feedback on that, you know, make sure you do write that, make sure you do write that, you know, temperature, whatever it is. So again, having that somebody else sort of looking at your notes, especially if you're new, will be absolutely fine to ask and say, do you think I've covered that okay? Do you think I've used the right template, whatever? Self-reflection, obviously, we learn from observing other people's notes as well. So, you know, again, being mindful of how people do it and how good practice might look like, you know, learn from that. And then I think we've got this, which we can put in the end, this link in the break that you can sort of use if there's a record keeping audit if you're interested in doing that. But just have a bit of reflection to make sure you know, you review your practice from time to time. Okay, thank you. So that's on to Minali again. Thank you.
Fantastic. Lovely. So what we're going to do is move on to safety netting. Okay. We're running a little bit behind time. So what I'm going to do is try to catch up as best as possible. So hopefully this won't be too whistle stop, but let us know if you have any questions as we go through. So safety netting, we'll touch upon what safety netting is, why we safety net and how we can do it safely, but also an element of documentation of said safety netting in the first place. So what is safety netting? So technically it's a consultation technique that we all use in practice. And what we mean by that is ensuring timely reassessment of symptoms should there be a need for reassessment. And it's aiming for patient safety. What we should be doing in all circumstances related to patients, clinical scenarios with all consultations is safety netting. But it's most important in certain scenarios. So say, for example, you've got a patient who's acutely unwell with an illness, you're suspecting something nasty or more sinister, such as cancer, or with mental health as well, when there might be a greater element of risk occurring. All these situations, for example, those acute illnesses, the cancer suspicion, or the mental health, they've got there's a possibility of things being worse than they are at the initial assessment. These things can always get worse, symptoms can vary, and there's always that element of possibility for deterioration. So it's providing that safety netting so that you're arriving at optimal patient safety, basically, and the patient knows when to seek help again if things were to worsen or change. The reason for it is that misdiagnoses in general practice are unfortunately inevitable. So what we mean by that is that there's no foolproof plan that 100% of the time and in 100% of our consultations, we can make every single perfect diagnosis, because there is a wide range of diagnoses available. Of course, we've only got 10 minutes. We've got limited investigation results to go on as well. So often you're managing risk and you're determining what things could be on a basis of the information that you receive during that consultation. So it's a process where people and patients are of low risk, but not of no risk. So that element of risk still remains, but what we're trying to do is mitigate it as much as possible. So what we mean by that is determining if the risk is there, and then determining what we do if that risk were to change. The reason for this is that no clinical decision we ever make as doctors or other healthcare professionals can ever be 100% sensitive, and nor can any diagnostic test be 100% sensitive either. So just to give you an example, say for example, a patient comes in with a cough. It's been going on for 3 or 4 weeks. They're a little bit wheezy. They used to be a smoker. You carry out a chest x-ray because you're worried there could be something nasty going on. That chest x-ray comes back normal. And you think, great, okay, that's wonderful. There's nothing nasty going on. However, that chest x-ray does not rule out cancer 100% of the time. It gives you an inkling, it gives you an idea that, okay, there's nothing found on the x-ray. That's great, it's reassuring. But if, however, the patient were to get worse, they would start losing weight, they would start bringing up blood, for example, that would alter things. And then that is the reason for the safety netting, if you see what I mean. The last few sentences of this slide goes through a little bit of the reason as to why we safety net as well. So coming back to the scenario of the patient with a cough, the individuals, they present at different stages in the evolution of illness. So some patients might present quite late on and therefore have a lot of symptoms to present with, and therefore you're more likely to reach a diagnosis. However, different diagnoses, some can be a little bit more gradually presenting or with vague symptoms, in which case you need to safety net a little bit more thoroughly. Red flag symptoms and signs might not be present as well. So especially at the early stages of something nasty, those symptoms might not be present. So it's important to inform the patient of what those red flag signs and symptoms are, so that they're aware of what to look out for. If those symptoms were to occur, then that's their reason to have to come back and seek medical advice again. Or the other way around, patients might present much later when the disease is too advanced. So again, it's important to safety net in that scenario as well. Any questions or thoughts about that? I do apologise because it's gone a little bit more clinical now, but hopefully there's something there for all of you. So why do we safety net? It's of course pretty obvious that of course it improves patient safety and helps to therefore reach a safer diagnosis, a more accurate diagnosis, and therefore hopefully reach a better prognosis for the patient as well. It encourages effective teamwork as well. So if we don't all work independently, we all work as teams nowadays. So it helps with colleagues following the patient journey as well, and helps ensure that everyone that you're working with within the team is aware of what's going on with the patient. Of course, it provides protection from a medical legal point of view as well. So say, for example, that patient were to deteriorate and they weren't aware that they were supposed to seek help again, that can lead to, of course, a delay in diagnosis, which of course can increase the risk of litigation as well. But then there's also an important function in terms of quality improvement as well. So in terms of appraisals, CQC, revalidation as well, it also plays a role with all of those as well. Any thoughts or points at all?
I was going to say, Minali, I know you said it was clinical, but actually that would apply to a lot of, for instance, mental health is an important one, where people might be presenting with depression and may have occasional thoughts of, but not too bad, or they've got no risks, but you obviously safety net and say, if your mood was to get worse, if your anxiety was to get worse, please contact us again. Then I put, if in urgent crisis situations, these are the crisis numbers, or call 111 or attend A&E. So that will be your safety netting. So yes, it's situation dependent, obviously, but safety netting essentially, I would say, like Minali's explained in summary, if you think things can change, you need to make patients aware that, if things change, ask help. And as long as you document that as well, they're safety netted by saying X, Y, and Z, then you basically medical legally covered, and it helps other people as well. So yeah.
Lovely. So thank you for that, Saira. So as we mentioned, how can you carry out safety netting? So it's about advising patients when they should come back for a review, or what symptoms or signs to worry about. So say, for example, from a mental health point of view, you might be assessing someone with mild depression, they're feeling a bit low, sleep might be a little bit affected, and an element of not enjoying what they used to do, but there's not much there in terms of risk. They've got good support around them, no thoughts of self-harm, no suicidal thoughts at all. But it's important to then document to the patient that if their mood were to deteriorate, or they were to start having any of those nasty thoughts, or they were to lose support networks, anything like that, then that's reason to seek review again, so that you can have that discussion just to ensure that they're still safe, and do that risk assessment all over again. That safety netting, it can be verbal or it can be written. So what we mean by that is that sometimes you might be providing patient information leaflets to a patient. You might be sending them a link to a website which has further information. I certainly do that all the time with my patients, send them little bits of information, signposting them to NHS websites, which do contain more detailed information about safety netting and when to seek help and what other diagnoses we could be thinking about. And then confirming that follow-up plan as well. So talking about when they should seek a routine review, and when, if things were to get worse, how they can hasten that appointment, and when they should hasten that appointment too. And then read coding and clear documentation, that's key as well. So what we want to do is ensure that from a read code point of view, things are clear in the notes, things are auditable, traceable, and making sure there's no ambiguity in the notes as well, to try to keep things as clear as possible. And that's especially important now that patients have access to their notes as well. So sometimes they might be reviewing the consultation notes after consultation just to check that they fully understood what went on. So I guess in a certain sense, there's that greater need for those for that documentation to be as clear and accurate as possible.
Mhm.
Lovely. So we've got a case scenario here, which will hopefully enable you all to put things into context a little bit better. I believe it is mental health related. I'll give you a couple of minutes to read that through. Lovely. So just in summary, we've got a 40-year-old man known to have depression. He's on medication, but he's lost his job recently and he lives at home. You call him up for a routine follow-up appointment and you tell him that he's fed up, he's not leaving the house, he's not in contact with his family and friends. What information do you think is crucial to document, and how would you safety net? So what further information would you like to find out from him? How would you perhaps assess risk, and what would you do in order to safety net this patient? Any thoughts? Do unmute and speak up if you want to, or
I think Livia's already put what protective factors, if he has got any suicidal plans, thoughts, or intention. Yeah, so absolutely, isn't it? That's the biggest thing, isn't it? The risk assessment. Fed up with the life, but what does that mean?
It's important to
Absolutely.
document the changes, so the next time you speak to him, you can see whether anything has moved within that. You know, whether it says he's lost his job recently, he's not leaving the house. It's also important to have them first-hand conversations around first aid in mental health. So whether he's got any, whether he's, you know, thinking things, whether he's considering harming himself, you know, just to get a good level of understanding how low his mood actually is. And then obviously safety netting by providing relevant numbers and support services that he can then tap into, you know, and then having that open door that he can come back to you if he feels the need to discuss that further.
Yeah, perfect.
fantastic, Yvonne, thank you. Yes, absolutely. It's those urgent emergency numbers as well. So contact with the crisis team, for example, the Samaritans, a little bit more information about when to either call 111, 999, or attend the emergency department if that risk is imminent. Any other thoughts from anyone else at all?
I usually ask what their safety net is.
Yeah, absolutely. So
Because some
finding out.
people will say that they're really low, but they'll go, oh, but I wouldn't do anything because my kids, they rely on me. So, you know that
Yeah.
they've got that personal safety net there, but then you can provide them with that professional safety net by giving those other numbers just in case things do spiral.
Absolutely. So finding out what their protective factors are, what's stopping them from acting on those dark thoughts. And Nicola quite rightly says, absolutely, potentially flag to the GP if felt appropriate. Absolutely. So if you are something like, I don't know, a social prescriber, health and wellbeing coach, or mental health worker, sometimes you do need to escalate. And if there is a patient that you're more concerned about and you think needs more of a, I guess, a medical assessment, so to speak, then absolutely, you'd be escalating up to whoever your clinical supervisor is in the workplace. To carry out a little bit more of a medical assessment, perhaps. Fantastic. So we'll just summarise this in detail. And another point to add is whether there's any element of alcohol or substance misuse, or has there been any prior history of use as well. Reason being is that can exacerbate the risk, unfortunately, and make them a little bit more of a risky patient, unfortunately. And then finding out a little bit more detail about the thoughts of self-harm or suicide if they do have them. So are they active thoughts? Have they made any plans? Have they ever tried it before? And then when it comes to the safety netting, document exactly what safety netting advice has been provided and when and who to contact. So be it GP, be it the crisis team, 111, emergency department, etc. So an example would be contact us again if you feel any worse or your mood dips further, but you could go into a little bit more detail about details provided regarding the Samaritans, etc. if you've got a patient who is of greater risk. Any questions or thoughts? Before, I believe it's just a final couple of slides before a quick break, okay? Because I realise we've run over time and I think it is certainly an opportunity to, we do need to stretch a little bit before we conclude. So just a few tips on safety netting, trying to be as smart as possible. And what we mean by that are smart objectives. So the specific, achievable, keep them realistic as well. So always giving the patient either a timeline or a reason or both, suggesting when they should be reassessed and the reasons as to why that is. Providing patient information leaflets or links to the NHS websites with reliable resources, hopefully, as to when they should be worrying about their symptoms. And being very, very specific with patients as to how they should access you. So this is especially relevant in general practice, depending what we do for a living. So it's well and easy to say, oh, just contact me if you're feeling worse. But actually, as you know, there's a ridiculous shortage of GP appointments out there. Access isn't easy depending on where one works as well. So making it clear to the patients how they can access you. So do they phone up reception? Do they message in remotely? Can they make use of an IT system where they can gain access to you more quickly? Or is there someone in the practice that can be a link, so to speak? So is there a particular receptionist or secretary or an administrator in the workplace who this patient will be able to have access to and say that, you know, things are worsened, I really need an appointment as soon as possible. And that's for the high risk patients. Obviously, we wouldn't recommend doing this for all our mental health patients, but if there are one or two who you are particularly concerned about, sometimes they're the ones to perhaps flag up to colleagues as being a little bit greater risk. Anything to add? Any questions? Or Saira, anything to?
No, I think it's time for a break. I think we're running a little bit over time, but that sounds good. Oh, you've got more. You've got more.
Just a couple more,
Just
yes.
the IT software thing, I guess. Yeah, carry on.
So just a note regarding referrals. I'm not sure how many of you carry these out, but it's important to read code high risk referrals. And what we mean by that is that if one is carrying out a 2-week wait referral or something a little very urgent like that, it's important to read code it for the audit trail. And ensuring from a secretarial point of view that referrals are carried out electronically rather than by paper and fax. That's been phased out now, fortunately, but obviously there's always that risk of faxes going missing. And having some element of tracking of the referrals as well, so ensuring that the people on the other end, an administrator, is receiving that referral and an appointment's been allocated. And then often, especially with 2-week waits, it's informing the patient that actually you should be getting an appointment within the next fortnight. And if you haven't received an appointment within the next fortnight, make sure you contact the surgery, because that goes to show there's been a breakdown in either that referral pathway or somewhere with the communication or somewhere with that appointment. So that is a reason for that to be chased after that fortnight is up, if that patient hasn't had their appointment yet. So things can need to be a little bit more proactively safety netted in these high risk scenarios. And a little bit of a bit about where we can use IT software to safety net. Again, not all of you will be involved in this, but it's just a little bit of an overview as to reminders that can be used. So for example, on system 1, you can make use of a recall system. Say for example, a patient's got diabetes, it's poorly controlled, but you want them to have another blood test in a few months' time. You can add something called a recall on the system, so that it's not the doctor's responsibility or the nurse's responsibility or the patient's responsibility. There is a recall in the system that would flag up automatically when that 3-month hits and that patient needs that blood test. And then you can have recalls for other things like cough reminders, and also for when patients haven't attended for their investigations that were required. You can make use of various IT platforms, so things like Accurisk, Ask My GP, and Patient Knows Best as well, to directly contact patients. That can sometimes be a little bit easier and a little bit faster than using telephone. Text reminders for patients as well. I know that my patients really love them, and most of them really want the test reminder just to say that they've got something in writing before their appointments. And it is proven that when you text a patient their appointment details, not just once but potentially twice, that reduces DNA rates, and that's the case for primary care as well as secondary care. And then making use of a messaging service that patients can use as well. So we do sometimes have systems, or something called an MJOG, I believe it is, on system 1, which I believe exists on UNIS as well, where patients can reply to messages as well, just the one time. So that can be a useful form of IT that can come in useful with safety netting. Any questions or thoughts at all before we have a quick break, which I think is much deserved? I do apologise for running over time. Hi everyone, welcome back. Hopefully you all managed to refresh yourselves. For this latter part of the presentation, I'm just going to hand over to Saira, who's going to provide a quick recap regarding consent, but then we'll be focusing largely on confidentiality. Thanks, Saira.
Yeah, thank you very much. Yeah, so consent is a topic on its own. Oh, okay, Livia. Yeah, that's fine. We'll let you in. So, yeah, so basically, hopefully you all have had some form of mandatory training in your, it was part of your package on consent, but also there is good GMC, General Medical Council guidance available, which are titled as Decision Making and Consent, that you could have a look at as well. Next, please. So what is consent? It's essentially giving a permission or agreement for something to happen, such as record sharing or examination. And it's very important to gain consent and record it. It is the 4th highest reason of complaints, where people have failed to gain or document consent where it is needed to be done. Obviously, some of it is implied consent. You know, I think staff, like for instance, I think I mentioned that already, that, you know, people, professionals within a team or within a organization or a surgery will have the access to patients' notes if they're directly related to the care. So we don't need to ask consent for them, are you okay for me to record it? Because I think that should be given, and, you know, that it's fine, you know, sort of don't need to consent for that. But at the same time, if there is sensitive information, or there are scenarios where you know, you kind of need to gain consent, you know, especially and particularly, I think we'll talk about confidentiality in a minute, but if you need to share the information sort of outside the organization, then you need to get consent from the patient. And this could be even things like commissioning or research, where you think that, oh, it's okay because I'm not, you know, doing any harm. I think it's important for patients to know, but it's a topic on its own. I think it's best to sort of read up, because if you had more time we would go into it, but I think I just want to concentrate on confidentiality. So next, please. So just going to go through quickly practical application of confidentiality, but again, please do refer to your mandatory training. So we're going to do a quick case study. I don't think we've got time for breakout rooms now, do we? So what I'm going to just go through it, if that's okay, and ask you directly or to write in the chat box. So Peter is a paramedic who makes a home visit, and to record a summary of the patient, he uses a paper record where he writes down patient's name, address, and date of birth. But due to workload pressures, the document is not entered onto the electronic record straight away, and it accidentally gets left into a different GP practice tea room the next day, triggering an information governance breach to be escalated. So we've talked about that already a lot, about home visits and things. So I think the discussion has already happened, but is there anything that you think that could be done differently to avoid this mistake? Let's concentrate on that. And what do you think are sort of confidentiality bits in there that need to be careful about? I think we've already had that discussion where Yvonne gave a really good example, but could someone else have a go at explaining? Or write in the chat, please. No? Are you all with us?
There's nothing in the chat so far, but personally, from my point of view, what was not done well is certainly using the paper records, where they've written down 3 patient identifiable bits of information: name, address, and date of birth. I don't think that was all necessary, in my view.
Yeah.
What else have we got? Helen, did you want to add something? I know that we finally got your camera on, so did you come on because you wanted to share something? But no pressure if you don't, that's okay. I don't want to pick on you. Emily says absolutely, not writing confidential details on a piece of paper, absolutely. So I think that was a step in the wrong direction to begin with, let alone, and then Olivia says taking the documents into the tea room, absolutely. So, I mean, that's a more of a recreational space, isn't it? Why was patient-related information taken into the tea room or kitchen in the first place? Yeah, the fact that they were taken into another surgery as well.
Yeah. So I think it goes back to where we said in the home visit, make sure it's done in a timely manner, get rid of it, shred it. Also trying to reduce the amount of information that you need. What is needed, essential bits is all what you need. So yeah, I think we've had that good discussion before, haven't we, Minali? So let's move on then. So what is confidentiality? Why do we have to follow it, and how do we do it? So let's talk a bit about that. So again, you have to follow your information governance mandatory training on it, but essentially to keep the information given by the patient or about the patient, to keep it safe and secure during a professional relationship is confidentiality. Next, please. So as a health or social care worker, you will come into contact with people that do give you personal information, okay? And this information, yeah, you need to be careful about why you would share it with anybody else. It should not be shared with anybody except those who are involved in direct patient care. And I think that's the most important thing to remember is you don't need to share it outside anybody other than putting it on online record. But if you think there is somebody who's directly involved in the patient care who wants to come and chat with you, that's fine. We're talking about more when sort of, we're referring it to other people. So for instance, you're doing a referral again to another individual or a profession, you need to gain that consent from patient to say, I'll be sharing these details with the hospital, which I think, again, is very given. Most of the times the patient would be like, yes, that's fine. But again, being mindful of certain sensitive information, do not breach confidentiality unless it's needed. And we're going to talk about the only scenarios where it may be necessary to breach the confidentiality. So, again, it may not be completely your decision. So breaching a confidentiality is a big thing, and it should ideally be an information governance lead that you should contact, or a Caldecott guardian. And it may be that you've just got a manager or someone who's got a responsibility for data protection. So do seek help from them if you're unsure. So the biggest thing is law. As in, if the law requires you to break a confidentiality, then it's fine. So investigating a crime is an example, police really needs your information. Again, preventing harm to person or others. So that's where the safeguarding thing comes as well. If there is an imminent, but so for instance, domestic violence is a little bit difficult one. You wouldn't just go out and talk to someone about it unless there's children involved, for instance. So again, there's no need to share information unless it's needed. So, but if that piece of information is needed to be shared because it will prevent harm to other people or is really risky for the patient, then that is an exception to confidentiality. If you've got an information governance lead, if you've got someone around you, your line manager or someone, just say to them, I think that I really need to, escalate this information. It's your clinical supervisor, whoever it is, have a discussion with them. But if you think there is an immediate risk, then share it, but then inform whoever the data protection person is or your line manager, whoever, so they can follow it up sort of in the legally, why it's been done. So I've had examples where court would ask for some information on some people, but it sometimes is tricky because you're like, patient doesn't want you consent, but is it in their benefit that we do release this information because there is an investigation and a crime going on? But these decisions are complex, and you will have a information governance lead or a guardian in your practice or organization that then need to go through these notes and say, yes, it's okay to do it. So most of the times I wouldn't do that, and take your time, make sure you've assessed the situation, and then do it only with sort of discussing with somebody who's a bit more sort of aware and in this area. But there will be occasion when there may be an immediate risk, something that somebody will literally come to and harm if you don't release this information to police, or if you don't send someone to A&E or something, situation based, and that's where I think it's okay to release the confidentiality. Next, please. So obviously, why do we keep everything confidential? It's very important for patient trust, and in fact, it's a legal requirement, really. Patients' right, even after death, to have their information sort of secret. Now, one of the really easy examples on a day-to-day basis would be a mother calling about a son or vice versa and saying, I'm the carer of this person. I really need to know what's going on. What did they discuss with you? I want to know. That's the biggest thing when it comes to confidentiality, to my mind. And the answer is no. If they're an adult and they've got a capacity, you cannot share that information with them. You say, unless there is a written consent there, either a person is present and you say, are you happy for me to share this information? If they're there with you and they say, yes, I'm okay for my mum to know, or I'm okay for my son to know, whatever, then that's fine. But generally, or if it's written in the documents, again on the homepage, if it's written to say written consent received, okay to discuss with this person, then that's fine. Okay, but again, do not release information to anybody. It's okay to talk to them, and if they want to inform you about the situation, then that's fine. So sometimes it's like something we call collateral history, where they might actually a patient's relative might have a really important input to make. So you can say, I'm really sorry, I can't share any. They might be ringing and say, I've got a serious concern about this person. You say, well, I'm really sorry, I can't release any information, but if there's something you want to tell me, yes, sure, I can put it in the notes. So something on those bases. Okay, I hope that clarifies. So have you got any questions or comments? Do we have more slides? Let's go through them and then we'll have a look at the comments. So only share patient information in a secure manner with consent. Now, again, sometimes the tasks within the system, for instance, are a secure manner of communicating with the reception or within the team, and that's fine. Same with NHS.net emails, they're fine, but never use, like, say, a normal personal email to pass any information, even if the patient's consent to do that. So obviously you need to be mindful of that. Very important, do not disclose details in public place. And again, that could be that if you're using a laptop, don't leave it open for someone else to read it. Don't, obviously, if you've talked about written letters, written notes, don't insecurely sort of leave them, you know, and always ask yourself whether a disclosure is necessary. And if it's not, in all kind of, you know, principle is do not release information unless it's deemed absolutely necessary. And try to obtain consent to share any data and discuss with the senior. So that's the summary of it. Next, please. And yeah, again, you know, if you're thinking about confidentiality, try and document your thinking process behind it as well. We've already spoken about the consent and 3 ID check if you're calling the patients to ensure you are talking to the right person. And then this last bit, I think it's a little bit tricky, but I think sometimes, I suppose, if you're not sure how, you know, you might have misunderstood patient, or the patient might think that you've not actually put the right words, you're okay to say to them, you know, I'm sharing this information, are you okay, you know, go over it. But this exceptions of safeguarding, you know, and adults and children, that's an exception. You have to let them know. But even if they say no to it, you are going to release confidentiality. So just remember those exceptional situations when patients are at harm or the others are at risk of harm. Also remember the IT safety, very important that you don't give your login details to anyone. Even within an organization, look after your smart card. Don't install any new softwares unless your line manager or, you know, says to you yes, because again, there's been information hacked in the past. Very common on the news we do hear that NHS software has been hacked, etc. So being careful about that. And social media is the biggest one where the confidentiality comes. You need to be really mindful of what we write on WhatsApp and what we write on Facebook and etc. Because yeah, as long as there's no patient identifiable information, you know, be mindful of confidentiality. So do you want to summarize the session, Minali, and then?
Yes, wonderful. Thank you, Saira. I do apologise for running a little bit late, but actually we're not doing too badly. We've managed to catch up. Does anyone have any final questions or thoughts at all? Just as a summary, we'll just go over what we've covered during our session. So a summary of our learning points. So initially we touched upon record keeping, how to record notes to ensure that they're not just clear and accurate, but also carried out timely. And in what ways might your practice or the way in which you record things change now that patients have access to their medical records. The importance of safety netting as well, and how you can safety net in order to try to prevent any misdiagnoses, and how you can record your safety netting as well. And then finally, we touched upon confidentiality. So who can you ask if you think confidentiality might need to be questioned, for example, if you think information might need to be shared beyond the patient, and what to do in terms of patient data and security. So when it comes to paper, when it comes to electronic records as well, what can you do in order to maintain confidentiality as much as possible? Does anyone have any questions or thoughts? I'll just have a quick look at the chats just to see. Yvonne's popped a few thoughts in there about social prescribers are usually gaining consent to share information from the outset, and therefore enabling referrals to be made with supporting information. Absolutely. So it depends very much what you do in your job role and what that first consultation with the patient involves. But depending what you do, sometimes that consent is taken at the beginning when you first meet a patient to potentially share information.